Good afternoon, everyone, and thank you for joining us for this CJCM webinar, Beyond NHI Perspectives to Renew the Public Healthcare System towards a CJCM policy to accelerate the deep just transition. As the Climate Justice Charter movement, we've been working hard to transform the systemic alternatives of the Charter, the systemic alternatives for transformative change envisioned in the Charter to policies for South Africa to accelerate the deep just transition. During Earth Day on the 22nd of April, we launched our Rights of Nature and Natural Climate Solutions policy for public comment. And on the 18th of May, in a forum with trade unions, we launched our eco-mobility and clean energy public transport policy, also as a draft for public engagement. Our food sovereignty policy, climate conscious media policy, zero waste and simple living policies are also on the pipeline. We will be launching our water policy on the 28th of August during our CJCM policy workshop. Today's webinar is an important discussion as we work towards a CJCM policy on emergency, holistic, and preventative healthcare, which is the 12th systemic alternative for transformative change in the Charter. We invite everyone to join a policy working group on any of these policies as we figure out the deep just transition together. To help us unpack today's topic, Beyond NHI, Perspectives to Renew the Public Healthcare System, we have Dr. Natalia Dinat and Mark Haywood. They will each have 10 to 15 minutes to present, and then we'll open it up for discussion. Dr. Natalia Dinat is a medical doctor, homeopath, and activist living and working in Johannesburg. She is a current convener of Science for the People of Southern Africa and is currently working on a doctoral thesis on homeopathy, philosophy of science, and critical realist perspective. Dr. Dinat, you have 10 to 15 minutes to present. Thank you so much, and over to you.
Thank you, Charles. Good afternoon, everyone. I'll just share my screen. So I'm going to be talking a little bit about the NHI. And before we go beyond it, I think we have to understand what it is. So I'll be talking about how the NHI is presented in the government, in the ANC and the Alliance, and in the media. What the NHI really is, I'll be presenting an alternative of what we should be demanding instead of the NHI. And then a little bit about why is this an emergency issue for democracy and eco-socialism. So the NHI is often seen as free universal healthcare and the ANC's answer to reducing inequity in access to healthcare and providing universal coverage. But it is really not universal health coverage. The NHI, which stands for National Health Insurance, is a funding mechanism. And I would argue that it's really been totally misrepresented by the politicians, to the extent where trade unions such as the NHI, which have backed the bill, has said access to quality healthcare is a right and should not be delayed any further by the interest of the private sector stakeholders, whose only concern is profiting for the people. So this idea that the NHI is going to do that, I think is really misrepresented. We all know that there's terrible inequality in healthcare, but the NHI is not going to fix that. So the three questions I think we should be asking is who receives the service, and is it really a universal access? Does everybody get to receive the service? The other issue is who runs the service or who manages it. But the most crucial issue for us to discuss with regards to the NHI is who owns the service. And as you can see, the NHI that's been proposed by the government now is that it will still be, services will still be owned privately. So why is this a problem? So the Lancet of June, Munyaradzo Makoni wrote about the South Africa passes its national health insurance bill. And he said it's received praise and criticism, praise from businesses, and he puts businesses first, opposition political parties, healthcare and professional groups and activists. So the idea for me is that the fight about the NHI has really been reduced to those people who are for it, and those people who are against it. And that's really been reduced to a class issue, because the people who are feeling that they could be against it would be the emerging national bourgeoisie. So, for example, opposing the bill in its current form would be the African Christian Democratic Party. And so while all the language against and for it is couched in this sort of ideas of equitable service and improved access and good healthcare, actually, it's really about who is going to make profit from it. And Discovery Health, for example, have just come to an agreement, and people are seeing that they can, these big international healthcare organizations are seeing where they can make a profit from it. So, it's a story that is really echoed in a documentary that's on YouTube by John Pilger around privatization of the NHS, the National Health Service, by stealth. And we have the privatization of our health service via mechanisms like the NHI by stealth. We inherited a publicly owned health system, which was actually organized after the war and with the onset of Verwoerd's apartheid system for publicly owned healthcare, really geared at giving a privileged white community good healthcare, although there was a private system running alongside it. And since 1994, we have been slowly privatizing healthcare services that were owned publicly. And for me, working in the hospitals, you could see that was happening during the Mbeki era, where I was working at the Chris Hani Baragwanath Hospital, and the bed sheets would used to have TPA on them, so they were publicly owned by provincial, but the provincial government. All the linen are now being provided at an enormously inflated cost by private companies. The same with catering, the same with medical equipment, etc. And, I argue that, well, when Thatcher, Reagan and Milton Friedman introduced free market capitalism, they prepared, and in type there, the policy of preparation for return to the private sector by stealth. This was from a report, I think, from McKinsey. This is how they're going to do it. They're going to steal. So always we'll find the language of NHI debates couched in very nice terms, but the real issue is who is going to own this system, or is it going to be a for-profit? So what we're seeing recently, so this was last week, SAA going private. This is a letter from Pravin Gordhan saying that he's giving permission, I approve the Eskom sale to privatize Eskom, basically. And slowly but surely, the publicly owned entities and services are being privatized. So in general, in the world, we have two universal funding, two models of care for universal healthcare funding. One of them is the Bismarck model, and those have really been used by countries that are very, very well developed and have moved from like a factory or a town having healthcare, well-developed healthcare services. And this is a sort of NHI type. I mean, our NHI or proposed NHI Act is really around, or bill, if it's still, is really around this kind of Bismarck model. The second model, and in this model, most hospitals and clinics are owned by the government, and most doctors and are employed by the government. And this, I would argue, so for example, the United Kingdom, although they're rapidly selling off and privatizing their health service, Sweden and New Zealand have this publicly owned service, which is what I argue we should be going for, not a national health insurance, which is a Bismarck model. So the NHS came into the UK as its essence a socialist policy. So at the end of World War II, soldiers were coming back radicalized. They'd fought this, laid down their lives in the fight against fascism, and they wanted socialist policies, and they fought hard for it, and they got it. And why is it important to have a publicly owned service? Because only then can it be not for profit. And I would really sort of argue that health care and profit do not go well together. You cannot serve both masters at the same time. The alternative, which some countries use, is a heavily regulated health service. In South Africa, and the NHI doesn't make any policy for that, or any allowance to have to regulate the pharmaceutical companies or the hospital industries. But that is an alternative that we know may be discussed. But I would really say that the only one that can work, it would be a publicly owned and therefore not for profit. So what do we see? What's the problem with free markets in health? So unregulated markets around the world have led to super profits. So last winter, the People's Vaccine Alliance, or in 2021, found that Pfizer had reached over $1,000 per second with a pre-tax annual profit of 34 billion. I mean, ridiculous profits. The unregulated market, because people just want to sell drugs, has directly led to this drug user epidemic, the opioid epidemic in USA, which is now the third leading cause of death of people in the USA. Huge waiting lists for people to get healthcare in the United Kingdom. The dropping of preventative services. So even in South Africa, that was dropped very early. So preventative health or promotional health services were dropped in favor of curative health services, because you can't make a profit when everybody's well. And really bad medical practices, not bad for the companies and the profit makers, but bad for the individual, such as in Gauteng, we have a 96% C-section rate in the private sector. So more women are dying and more babies are dying because of this than if they were allowed to have a natural birth. But C-sections generate a lot more profit than natural births. We have epidemics of obesity coupled with malnutrition. So though people are obese, they are still lacking in nutrition and nourishment and vitamins. And we have experienced huge death rates in COVID. So when you compare to China and Cuba, which run generally not-for-profit healthcare, the Chinese government spent a lot of money enforcing their anti-COVID regulations. And the companies that have this unregulated market, like the US, just suffered enormous death rates. Same thing with Brazil, they had enormous death rates. So the free market generally around the world can see to be is not good for health. People are given unnecessary antibiotics, unnecessary antidepressants, and they're not given the right care when they need it. So the Lancet published a paper, which was an editorial in March of this year, and they have described commercial determinants of. So they say that this is a new thing in healthcare, that the private sector activities can and do impact public health, either positively or negatively. And they do show in this paper that the climate emergency, the non-communicable disease epidemic, and just 4 industry sectors, so the tobacco industry, ultra-processed food industry, fossil fuel, and alcohol, already account for at least 1/3 of global deaths. So the idea of profits and the commercial sector they show to be underlying and driving all of these problems. So, and they explain how the shift towards market fundamentalism and increasingly powerful transnational corporations has created a pathological system in which commercial actors are increasingly enabled to cause harm and externalize the cost of doing so. So they could cause harm and make a profit at the same time. So consequently, as harms to humans and planetary health increases, the commercial sector wealth and power increases, whilst the countervailing forces have to meet this cost, which is us, basically. The Lancet asks that communities, civil societies, and government and philanthropists, where aligned, must work together to achieve health for all. And I would say that this is really a big conflict of interests. So I think it's beginning to be understood that business is not good for health. And here are some other problems caused by capitalism. Violence against humans, nature, and the earth. So mental health, we are extremely alienated from each other, from our work. People are working and working and working, but not feeling the fruits of their labor, and from nature. This has led to an increase in autoimmune disease, suicides, addictions, intimate partner violence, depression, and drug abuse. Women's health, both in terms of policies and these determinants of health or profit drive, are also taking a knock, as I've shown you with the C-section rate in South Africa. Obesity, malnutrition, ultra-processed food lead directly to high blood pressure, diabetes, and even listeriosis, because cutting corners and profit-making was shown to be at the root of the listeriosis outbreak, when we were sold this sort of like highly processed meat that was full of the bacteria. And it's having an assault on the environment. So degrading the air, the soil and the land, the water, the violence towards animals, that's livestock, as well as wild animals, are causing cancer, autoimmune, and also mental health issues. So what have we in the left or in the civil society done? So I found it's a very dated paper from November 2011. And this was a discussion paper that looked at several points. So they basically said that, you know, we welcome that there's something that can be done, there's some positive aspects, but there are concerns, and they're worried about the cost concern, they're worried about the tax subsidies, they're concerned about, you know, will there be a new health tax? What kind of healthcare, user fee and co-payments, accreditation of healthcare service providers, building hospitals with private partnerships, public-private partnerships, how the NHI fund is going to work with Department of Health, information and protection, so our data and implementation, and the coverage and exclusion of undocumented migrants. These were all raised as issues, which I found was sort of technocratic response to a political issue. And only on the sort of 8th point, or the 7th point, building of flagship hospitals, was there sort of squirreled in that the building of public hospitals should not be a source of profit for private companies and should remain wholly owned and managed by the public sector. And I would argue that really this needs to be the front thing, is that the whole health service needs to be publicly owned. Otherwise, we're not going to get what we want. We cannot provide healthcare that is equitable and decent if we're going to have the profit motive in place. So I would say that, yeah, publicly owned National Health Service, and we cannot reconcile profit with healthcare. I don't think there's any sort of medium road, in my opinion. Lots of people say they can't afford it, or we can't afford it, but Britain post-war was bankrupt and they built their NHS. Cuba wasn't the richest country at the time of the Cuban Revolution. Vietnam had been devastated by carpet bombing with napalm by the Americans. China, the Soviet Union were all really poor, and they started to build publicly owned services. I would argue that this is not what both international capital and local capital want, because of people that are free from fear. You know, the fear of, will I get sick? Will I be able to afford it? What happens if my mum gets sick? That fear keeps our heads down and really does oppress us. So if we're free from that fear, if we're strong, physically strong, if we're healthy, if we're resilient, if we're inventive, we will then be able to fight the capitalists, and they really don't want to see that. So what we want is health, well-being, happiness. We want to be able to grow and develop and live in the community, helping others. That is what human beings want. What capitalists want is power and profit. And I mean, the market is enormous. I think second to the military-industrial complex, the pharmaceutical industry is the second biggest profit-making industry sector. So Marx and Engels outlined the fundamental contradiction of private profit and social care. So this leads to the other contradictions that we're seeing in our world: climate disaster, economic and geopolitical, wars and the threat of annihilation, which are all bad for our health. So all of these will lead to mass migration, which we're already seeing, increasing poverty, debt, and inequality. Bad food will lead to bad health. Bad drugs will lead to death. And always the problem with the answer that we're seeing is an increasing or a rise of right-wing fascism that's proposing to answer, these problems of migration and blaming other people for the problem when it's not them. So what can we do? And I think the bottom line is we need publicly owned services, especially in health and education. Some ideas around solidarity, I think, is important. I think we need to be aware that there will be a backlash, and be aware that these fights that we're seeing in the arguments in the NHI that we're listening to on the radio are really fights between international capital and the local emerging bourgeoisie. And we need to be clear that we support neither of these groups. So, okay, I'm not going to go there. So just to finish up, I saw this on Facebook, that humans really are the consciousness of the earth and of nature. And we have stewarded the earth for millennia. But in the past 200 years, capitalism has destroyed species, eroded soils, poisoned rivers and the air, and is killing all living things. And I don't think we can really run away from that. We can't always keep our argument just on health, because our mother is dying, our earth is dying, and her children are malnourished, homeless, and sick. And this is really the fundamental issue. So as Marx and Engels said then, which is absolutely relevant today. The choice is one of between socialism or exterminism. Thank you. How did I do for time?
Thank you so much, Natalia. You've raised so many points which we will delve into in the discussion. Thank you so much for your input. Next, we have Mark Haywood. Mark is an activist, co-founder of Tech and Section 27, currently editor at Maverick Citizen. Mark, over to you.
Thanks, Charles, and thanks, Natalia, and thanks to the Climate Justice Charter Movement for organizing this discussion. I think it is timely and necessary, and it's also very important that we stop seeing the climate crisis and the health crisis in silos, and that we understand that the climate crisis and climate activism must merge with health activism and health justice activism, and health justice activism must merge with climate crisis activism. I obviously agree with what Natalia has said and with her analysis overall. I want to take a slightly different approach to my input into this discussion, which is really to spend more time on the immediate context facing health in South Africa and also facing health internationally. I know that within the climate crisis movement and within the left, we talk about the fact that we are now engulfed in a polycrisis. It seems to be the new in word, the polycrisis, the global polycrisis, that we beset by multiple concurrent crises in a way that is almost unprecedented. But the first thing that I want to say to you is that the polycrisis in society is mirrored and is feeding a polycrisis in health, in state of health, in wellness, and in vulnerability to ill health. So you have to have this discussion understanding that health is not standing still, obliging us, that in fact, the health crisis is deepening literally by the day. There are at least 4 prongs to the health crisis, each of which interacts to some degree with the other and compounds the other. We have a crisis of non-communicable diseases, cancers, diabetes, and so on, which are being driven, as Natalia said, in particular by commercial determinants of health, by the shit that we get fed and that we are profited from, causing a whole variety of cancers. And it's an area that I think all of us need to become much more familiar with, but non-communicable diseases are exploding. We have a crisis of infectious disease. A few years ago, people were beginning to think that perhaps we were getting on top of pandemics and infectious disease, but then along came COVID-19. COVID-19 cost, according to the World Health Organization, 15 to 16 million lives, but has left a broken healthcare system, has left many millions of people with long COVID and many millions of people with long COVID and no health systems to support them manage that. But the environmental and climate crisis is also driving the infectious disease crisis. No one knows when exactly, but the idea that there could be further pandemics, viral pandemics, further influenza pandemics, is by no means, is by no means far-fetched. And the world is in fact presently preparing, and activists are working on, sorry, I just have to move for the dog. And activists are working on with the World Health Organization on a global pandemic preparedness treaty. Unfortunately, as is the case with climate crisis negotiations, the World Health Organization is captured in many parts by organizations like the Gates Foundation. And therefore, when it comes to this pandemic preparedness treaty, there is again a struggle over how strong and how rights-based the treaty should be and the powers that should be given to states versus to the private sector under that treaty. So that's the second prong. The third prong is a crisis of violence against women, violence of men against men, violence caused by car and other injuries, violence caused by guns. And the fourth crisis is a crisis that is linked to worsening maternal and child health. If you look at an article that I wrote today, just look at the state of child health in South Africa at the moment. In 2 of our provinces, the incidence of severe acute malnutrition is now over 6% in children. So all of these health issues are on the rise. And as I said, you can't put them into silos and separate them from each other. But whilst the health crisis is deepening, what we also see is that the health systems that we need to address the health crisis are getting weaker and weaker. Health funding is decreasing. I don't know about the global statistics, but certainly in South Africa, we're about to institute another 10 billion rand in cuts to the public healthcare system because the cabinet has declared that the current public sector wage increase is unfunded and must therefore come out of existing departmental budgets. Per capita expenditure on health has anyway been going down in the public health system since 2012. We're facing, as Natalia can explain better than me as a health worker, a crisis of human resources. We have a 2030 human resource plan, but no budget, no plan to implement that budget. And we're facing a crisis of health infrastructure and of access to medicines and access to medical devices. All of this, comrades, is creating a perfect storm when it comes to human health, therefore to human dignity, therefore to human education. Again, just as you can't separate climate from health, you cannot separate human health from human well-being, from access to employment, from equality, from dignity, and so on and so on. And as Natalia said, and I'm rushing now, but a great deal of this has to do with the mismanagement of the health system and the systematic disinvestment and disinterest in public health. And I think, coming now to this question of NHI, when we talk about NHI, we can't separate it from the track record of both government and the private healthcare sector towards health in South Africa over the last 10 years, and particularly the last 10 years. I would probably use language. Natalia has given a kind of historical analysis of where NHI comes from. But, as a health activist like Natalia, I would say that the NHI proposal is an opportunistic, populist ploy that uses the rhetoric of equality and anti-private sector and anti-power to hide the fact that we have not been using powers that the state already has to regulate the health market, as the state is allowed to do in terms of our constitutional right of everyone to have access to healthcare services and rights of children, an unqualified right of children to basic healthcare services. So we talk left, we talk anti-private, as Natalia said. We're going to take on the medical schemes, we're going to take on the private hospitals, etc. But in reality, we don't use the powers that are already in our hands. What do I mean by that? Well, we have one instance where the state did act, and that was when it was driven by activism by the TAC to bring down the prices of antiretroviral medicines. But it has never acted around medicine prices to do with cancer, to do with diabetes, to do with any of the other conditions that kill poor people in South Africa. And yet it has exactly those same powers. Natalia knows much more about non-communicable diseases and cancer than I do. But basically, poor people die of cancer, not because all cancers are untreatable. They die of cancer because the state does not purchase the best medicines at affordable prices. What have we done to regulate medical aid schemes? If I was clever in putting up a graph, I would show you that basically since 2008, 2009, private sector regulation and reform has ceased completely because the government has concentrated only on national health insurance. Now, we may have an ideological debate about whether we want to regulate the private sector or whether we want to take over and have full public ownership. But my argument is that if you have powers to regulate private healthcare, to make it more affordable, to make it more transparent, to make it more accountable, to make it lead to better outcomes, then you should use those powers on your transition to a primarily public-owned and publicly driven health system. As a doctor I spoke to recently said to me, the biggest threat to private healthcare is an efficient public healthcare system. That is what would kill private healthcare. But as I've said, we have been disinvesting from public healthcare whilst not taking measures against private healthcare. The other thing I would point out to you, Natalia didn't mention it, the Competition Commission spent 120 million rand on an inquiry into the private healthcare sector. It produced a report in 2019 with a set of recommendations to regulate the private healthcare sector. Again, it is reform, but it's quite serious reform, but nothing has been done about it. So opportunities to narrow inequalities in health and to improve the quality of health have been missed. And the final thing that I would say on this, Natalia did mention, is there are serious issues to do with the commercial determinants of health. We, as a country, gazetted something called a National Health Commission in 2017, and we haven't done anything about it. And the purpose of a National Health Commission is to allow stronger regulation of alcohol, tobacco, ultra-processed foodstuffs, sugar-sweetened beverages, and so on. And we impose a sugar on sugar-sweetened beverages, but then we don't increase it because we're afraid of the sugar industry. So all the left talk about universal access and equality, etc., around NHI view is intended as a red herring. We have universal access to basic education in South Africa that we have achieved since 1994, but it hasn't brought about quality basic education. And the last thing that I want to say about NHI, which we should understand, as Natalia said, is it's not actually about the services that are provided. What is on the table in the NHI bill at the moment is a funding mechanism, is a proposal to establish a 1 trillion rand a year budget public enterprise that will act as a single purchaser of healthcare facilities from a decentralized district-based healthcare system. So what's on the table is anyway very long way away from quality healthcare. NHI, as Natalia has also said, is also not new. NHI was first mooted in South Africa by people called the Gluckmans in the 1940s. In fact, two white progressive doctors who were thinking about equal access to quality healthcare before the beginnings of apartheid. But you know, the biggest problem with NHI is that it has delayed the radical reconstruction and reform of the healthcare system that we need. The biggest problems at the moment are management of healthcare systems. And yet NHI proposes creating a massive, massive new management system, and corruption, which is costing 50 billion rand a year, spread equally off the public and the private healthcare sectors. So I want to just finish by saying, well, what should the agenda be? I think, as I started off by saying, the climate justice movement and the health movement have to do much more to tie the knots between the climate crisis and the health crisis. We have to show what global heating does to health, what it does to child health, what it does to disease. We have to make that a further reason why we have to control and stop fossil fuels. So those we need to do. But then we need to I would say the Climate Justice Charter movement needs to discuss with the People's Health Movement, with the Treatment Action Campaign, with others, how do we reinvigorate a health activist agenda in this country that is focused on fixing the healthcare systems? And specifically, I would put forward, I think, 4 or 5 things. We need this National Health Commission. We need much, much more work on public, on the regulation of the determinants of ill health. We need to stop the budget cuts to the healthcare system. We need serious pandemic preparedness. We have dropped all of our preparedness since the end of the COVID-19 pandemic. We have to improve public management of the public healthcare system and the quality of care and services in the public healthcare system. And we have to expedite investigation and prosecution and recovery of large amounts of monies from corruption. I believe if we followed a path like that, then we would be in a better position to tackle the converging crises of disease and vulnerability to ill health and global warming and environmental destruction. Thank you. I'll stop there.
Thank you so much, Mark. Thank you so much for your input. Thank you to Natalia as well. We will now open it up for discussion with all the attendees. If you have a point to raise, or if you have a question to ask, feel free to raise your hand, and I will allow you to speak. You've both taken us beyond the narrow debate that we have been seeing on the NHI bill to actually discuss some of the underlying things behind it. One of them being, of course, what Natalia referred to as stealth privatization, which of course is part of this idea of endless consumerism, that we can simply medicate ourselves into a healthy environment while rejecting and ignoring the importance of interspecies health as well as interspecies justice, because as you said, Mark, at the end of the day, it's a polycrisis. It's an environmental crisis, as we are seeing with the unbelievable extinction rates, the destruction of ecosystems, the destruction of the natural world, basically. And it's impacting on us as humans. And until we fix that and we deal with that, we cannot sort of have an anthropocentric approach towards healthcare systems. I have some questions, but I will allow attendees to speak. I see a hand from Marjorie. Marjorie, please unmute yourself. Thank you. Marjorie, are you there? Please unmute yourself.
So sorry, I was doing this in the car and I didn't actually have my hand up. My apologies.
All right. Okay. Sorry. No problem. So one of the things I'd like to ask the two of you, Natalia and Mark, the NHI talks about hospitals as semi-autonomous entities. Now, what does that mean actually in the management of hospitals? And is it the best approach that we need in terms of dealing with the mismanagement in hospitals, the maladministration and the corruption we have seen in hospitals? So I'd like your comment on that.
Natalia, do you want to go first?
Shall I go? Yeah, I mean, when we're talking about mismanagement, so for me, a for-profit, a commodification of healthcare actually encourages mismanagement, because then you can be corrupt and you can steal more and make more profit. And as I said, you know, the people that are stealing crudely, you know, are the, you know, emerging bourgeoisie. And the people that are stealing, you know, in a most legal manner are the people like Pfizer and, you know, the big health corporations. So that's the one thing. If you have health as a non-commoditized industry, then or entity and service, it automatically, you know, it's not in anybody's interest to have mismanagement, because there's nothing to steal, because there's no profit motive. So that's the one thing. So I think to minimize the mismanagement, we need to really focus on the idea. And I mean, there is a big discussion about whether there's a path, and we reform and reform towards a full NHI. I don't think we have time for that. I think we are in an emergency, as Mark really clearly put out, of many, you know, this polycrisis of Mark's. And I think that and if you don't fight for something, you'll never get it, you know. And lots of people around the world have shown that if they make this a demand that we want a publicly owned service, I think we have to demand that and not have this sort of creep towards or more and more regulated. So I think, and that takes a bold vision and a bold statement. So I think that's around the mismanagement issue. You can obviously, and health is enormously complex, and the health services are enormously complex, but you can try and minimize the mismanagement. But if I look at, I grew up in the United Kingdom during a time when the NHS, you know, was its heyday, and never worried about needing operations or care or medicine or anything else, and can see now that the more you privatize things, the more people, you know, people don't get access, the more mismanagement there is and the more problems there are. It's not peculiar to South Africa, this issue of stealing and mismanagement and corruption. It's, you know, 10 times worse in the UK. So I think that if we keep focused on the idea that this is what we want non-commodified. The rest of it are technical issues, you know, that we will be able to address.
Charles, I'll just say briefly to add on to Natalia, you know, I do think that activists need to be on top of what is actually proposed in the bill, so that we can argue around it convincingly. As I said, it creates a national, that's primarily about creating a fund to allow what's called a single payer that in theory would pool money that currently goes separately into the private sector and the public sector into one big fund, and then would purchase all medical services out of that fund from districts. When it comes to hospitals, in theory, what this would do is that it would not distinguish anymore between public and private hospitals. Hospitals would be accredited to provide medical services, and the fund would set a per capita fee for services projected in advance that would be supplied by that particular health facility. So again, in theory, if I live in Hillbrow, I could choose to walk into the Park Lane Hospital, or I could choose to walk into Charlotte Maclearcare Hospital, because they're both National Health Insurance accredited. But that presumes a number of things. First of all, as somebody said in the commentary, private healthcare, it may look like a 5-star hotel, but the quality of medical care in those hospitals is often not as good as the quality in the public healthcare sector. Public healthcare may look like it looks like, but there is often good quality care, but long queues, insufficient medicines, etc. But what do you have to do to get the public healthcare system up to a level that can meet accreditation? You have to invest a lot of money in it in the first place, not starve it. And what do you have to do to get the private sector so that it meets outcome accreditation, not just 5-star hotel, nice receptions and pretty rooms accreditation? Then you have to manage quality of care in the healthcare system. So that's what it, and that's the context to your question about where do these different units, where do hospitals, etc. fit? You know, there's a big discussion, there's a whole set of discussions around hospitals. As Louis and other people will tell you, one of the problems we have in this country is not that we don't need hospitals, we do need hospitals. Of course we need hospitals, they are a part of our healthcare system, but we have become hospice-centric, we have become curative. We don't prevent diabetes, we don't prevent cancer, we don't prevent tuberculosis, we don't even prevent HIV at the moment. We wait for all of those people to get sick with all of those things and then to present in underfunded tertiary hospitals. So we have to go back to the basics. You know, you look at the white paper in 1994 or whatever it was, you know, the vision was right then. But my personal view, and some of you will disagree with me on this, and that's fine, but my personal view is that we have to fix the public sector, we have to get the money into the public sector, we have to constrict the private sector through effective regulation. Once we've got the public sector improved, as Lenin, who we like to quote, used to say of the state, the private sector will wither away when there is an effective, organized public sector. The private sector at the moment thrives on the fact that the public sector is so weak, including, sadly, most of us here on this call who sit rather hypocritically as consumers of private healthcare rather than public healthcare. So there's a few changes we have to make there as well, because we reflect that very contradiction, that because public is weak, we in our jobs accept private, and that is wrong.
Thank you so much, Mark. There's a hand from Louis Reynolds. Louis, please go ahead.
Thanks very much. I don't know where to start, actually. I think, I totally agree we need a single publicly owned, publicly funded National Health Service, funded mainly by tax, that provides healthcare according to need rather than means. But I want to go on to somewhere, I want to link our current system and the NHI proposal, or let's call it an NHI project, with the climate crisis. Now, the world's health systems that are based, on sort of Western capitalist models, if they were a country, they would be the 5th biggest greenhouse gas producer of all countries. The world's health systems produce more greenhouse gases than the continent of Africa. So we need from this NHI project, we need a health system that's not only publicly owned and run and so on. We need a green health system, one that does not produce greenhouse gases. And, it's generally agreed now that the climate crisis is the biggest health crisis that we face. And it's unhealthy not only for humans, but for every living thing, as has been said on this webinar. And it's the hospital-centeredness of healthcare and the kind of waste, not only the waste from corruption, but the waste from packaging the waste from transport, transport of patients, staff, equipment, medicines, and the waste material that's produced. The hospital where I did my internship, Kruitsky Hospital, a few years ago, was burning 10 tons of coal every day. I mean, that's just unbelievable. So we need health systems that move out of hospitals and into the community. We need a radical rethink of how we do healthcare and how we think about health. I think I'll stop there, but I think this charter, I don't know if there is a charter available online, but I would like to have sight of it. I think we need a really radical rethink about health and healthcare. I think I'll stop there and hand over to others. Thanks very much.
Thank you very much, Louis. And Natalia, I see your hand, but can I please take Peter, and then I'll give you both and Mark an opportunity to respond after those two comments. Peter, you can unmute.
Oh, great. Thank you very much. My name is Peter Benjamin with the People's Health Movement, but also with Extinction Rebellion, a climate protest group. Thank you so much to both of the speakers. Really interesting discussion so far. And I think what everyone is saying is that the crisis in health is in many ways driven by the same causes as the climate crisis, the capitalist class, whether it's private health on the one side, or in particular the fossil fuel industries that are absolutely driving the cataclysm we're finding throughout the planet. The government is treating these separately. I mean, there's the Department of Health hardly talks to, for example, the Department of Forestry, Fisheries and Environment, or actually more importantly, Minister Gwede Mantashe in the Department of Energy and Mineral Resources. My question is, can this workshop and some things like that help build a partnership between the activist groups in the two different sectors that largely aren't doing that much work together? To say the obvious, the climate is already having direct health impacts on people. From immediate things, the death from the coal-fired power stations in Mpumalanga are hugely bad for particulate for respiration. And there was a study, I think several hundred people have been killed by that. In Limpopo, there's now malaria. As the temperature changes, the areas in which various insects, such as the mosquitoes that carry malaria, move. Therefore, the areas that are infected by malaria also go wider. We know of the rain bomb in KwaZulu-Natal that killed many dozens, Typhoon Idai recently in Mozambique, crop failures in the Eastern Cape. The climate and ecological crisis is already directly having impact on people's health here. So my question is this: over many decades, our two speakers have been very involved in the health activism, which has got very strong community roots, history of mass mobilization, using the courts very effectively. The environmental groups are largely distinct. Respect absolutely to the Climate Justice Charter. There's a separate climate justice movement, Extinction Rebellion, dozens of others. And there's such urgency, particularly this decade, to get so many things. We have to get carbon neutrality by 2030 in the climate crisis, and learning ways of doing more dramatic, in-your-face mobilizing and activism. So my question to the speakers and anyone else here: how can we build a more coherent joint movement between the two? It's very sad to see two sorts of crises that look and are talked about separately that are just different faces of the same thing. Thank you very much, comrades.
Thank you very much, Peter. We appreciate your input. Natalia, you'll go first, and then Mark, responding to Louis's point on decarbonizing our hospitals and Peter's point on building unities and convergences. Natalia, you can go first. Thank you.
Thanks. I'm in full agreement. I'll start with Peter's point. And I like that there are different faces of the same thing. So again, from my perspective, we need a system change, and we need to look at all of this as single issues. At the same time, people in their day-to-day lives are facing specific issues. And I think we should be supporting. So that's what my slide, or I rushed through those slides. The point about solidarity. If my, as a woman in, whatever area, my issue is access to seeds or, a mining company, then answering Peter's point, how do we work together? I think the overall demands should be clearly articulated, and we need a system change because capitalism isn't going to fix this itself. But I think at the same time, we need to acknowledge and support one another's struggles, which are specific and local or hyperlocal, and we really need to pay attention to that, because I think that's just one way of mobilizing. So if one person's struggle is access to their children's anti-epileptic drugs, or facing drug abuse or violence, we need to say, okay, we support those people's struggles. So that was the one issue. And I think around Louis' point of hospital-centeredness, I agree with you, Louis. And I mean, so I was also in the Soviet Union in the last dying days or the end of the Soviet Union for 7 years. And in that system, I mean, they weren't incredibly wealthy as a country, but every single person, including me as a student there, had to undergo a full physical examination. And that preventative healthcare worked really, really well. So all over the world, people have been, and even today in Brazil, they're having really inventive primary healthcare health initiatives. In Cuba, they're doing fantastic work. Mao's barefoot doctors in Vietnam, they did really good work. So we don't always have to, I agree, do what has already been done in terms of fancy hospitals. But at the same time, I would sort of argue about an issue of not so much historic redressing, but proportionality. As you mentioned, Louis, in Africa, we use a fraction of the carbon emissions, in hospitals, as you said. So why can't we then, we do need hospitals. We absolutely do need hospitals. And yes, we can make them greener in many ways. But to say that, we need to only concentrate on primary healthcare or barefoot doctors, no, we also need and deserve, and especially with the traumatic events that are going to happen, state-of-the-art surgical care. We need that. And we need these fancy hospitals, and we need them open to everybody. So that's the other thing. I'm not so sort of like interested in this fight about the private sector withering away, or, anti-private and pro-public sector. I think that if healthcare, again, if we look at publicly owned, not-for-profit healthcare, that is the issue we need to concentrate, not on sort of saying, or making people feel bad. And I addressed a shop steward meeting of Nehao, and I think there were hundreds of shop stewards there, and they all have medical aid, and they were all proponents of the private system, and they all didn't want to go to Barra and sit with somebody in the next bed who was homeless or or poor. They wanted those fancy systems. So I think that, as Mark said, if we do have a not-for-profit health system, we will have good health, and the private sector will wither away. But I don't think it needs to be sort of like an objective of ours. And I don't think we need to be anti-private sector. I think everybody's trying to get the best healthcare for their loved ones. And I agree with you. So a friend of mine who's a cancer patient in London broke her thumb, went to King's College, which is one of the best hospitals in the world. I think it's an academic hospital. They'd privatized the small trauma unit or minor trauma unit. And the doctor there said, well, the x-rays that they've given us are so bad, I can't see anything and I can't get your cancer notes. So obviously, and she was getting now worse healthcare in this privatized system. So privatization definitely doesn't come with many, many benefits. The last 2 points I want to make is that the evidence shows that the Bismarck model of NHI, National Health Insurance or Social Health Insurance, actually, they found tends to exacerbate rather than redress inequalities. And I would argue that is going to happen with our NHI bill as it stands, because we're not asking for a publicly owned, we're just looking at who receives healthcare. And, you know, major profits are going to be made out of that. And then my last point is my big bugbear that I'm obsessed with, not only in terms of carbon emissions, when we look at the environment and degradation of the environment, we need to address this issue that antidepressants, for example, which are handed out willy-nilly, are not degraded in the water system, find their way into all the waters of the world. And they found that in pristine lakes in Sweden, the fish are altering their behavior and are having disinhibited behavior because of these antidepressants. And the same thing with hormones. In Mexico City, they found out that the fish, again, were changing their sex because of the high levels of hormones in the water. I would make Pfizer and Eli Lilly and all the makers of antidepressants provide people with something to dispose of their urines. It doesn't get into our water system. So in general, these health, the degradation of the environment is very, very broad, and we need to sort of address all of that. So yeah, thank you for my little rant on those issues. Thanks.
Thank you, Natalia. Mark?
Yeah, just to add a little bit on the basis of Natalia's comments and the questions. You know, obviously, as Louis said, we need a green health system. And it's very interesting. I didn't know those figures about how the health system contributes to greenhouse gases. Similarly, our food system. I think our food system is an even bigger contributor to greenhouse gases than our healthcare system. And again, our food systems and food activism and food justice activism must be part of this discussion. You know, the thing that perplexes me is we can say we need a green health system. The question I want us to answer collectively, if we can't do it today, which we probably can't, is how we get there, so that we actually have a pathway between this ideal vision and where we are at this precise moment in time. And if we don't find that pathway fast, and if we don't find a pathway that resonates with people like the Nahawu shop stewards that Natalia mentioned, then we are just going to continue speaking to ourselves in little huddles like we are today, when the vast majority of people are outside of these discussions and outside of these discourses. So, you know, I've been a socialist all my life. You know, from about the age of 14 or 15, I can see that capitalism is now in a terminal crisis, much worse than we imagined when I was growing up in the 1980s and so on. But I can tell you that we're not going to be able to take ownership of the private hospitals tomorrow morning without creating a disruption that can lead to a worsening of healthcare for people. So what, again, is the route between getting to a predominantly publicly owned healthcare system, overwhelmingly publicly owned healthcare system, and the situation where we are in today. That's the question that I think we have to try to answer. And I think that's why, you know, when Natalia talks about hyper-local struggles, about how we ally with people who face life and death issues in the health system today and face the indignity, and get them and their families on board, and get people who are most vulnerable to the climate crisis in the way that Peter described on board. That is the question. People are dying of cancer today. I've been doing some work in the last few weeks on what are called stoma patients, at least 60,000 people in South Africa who wear colostomy pouches, urostomy pouches, who can't get these out of the public sector, so go home to their families using plastic bags attached to the holes in their stomachs. What are we doing? What are we doing about sexual and reproductive healthcare services? You know, those are, I think, some of the questions that we have to ask. And I would finish by saying that we do have to ask questions about ourselves as activists, because part of the problem is we're part of the problem. As I said a minute ago, we live in elite suburbs. We are mostly on medical aids. We are mostly on the high end of the wage spectrum. We are invested in this very society that we are criticizing, sadly, at this moment in time. And that is why quite often we lack legitimacy amongst the vast number of people who are actually cut out of it. And we've got to find a way to overcome that crisis, because otherwise we don't have the luxury now. I mean, as Peter Benjamin described, the climate crisis won't wait for us. You can't build a climate justice movement, a few thousand people a year, over the next 5 years. Will be consumed long before the movement is big enough to shape and to reshape power. So the questions that Peter is arguing about how activists work, about how we work together, about how we get out of our comfort and privilege zones, about how we define the agenda, about how we take risks, about how we get more visible, about how we get more imaginative, about how we use a language that ordinary people can actually understand, I think are critical questions for this time. Sorry, I ranted as well.
Thank you, Mark and Natalia. What is increasingly clear from this conversation is that what we need are systemic alternatives. Shallow market-led approaches like the NHI, which are just funding mechanisms, which not fundamentally transform the healthcare system, are not going to cut it, especially in an age where climate shocks are not only increasing in frequency, they are increasing in intensity as well, and they're affecting so many people. And those who are least responsible are always paying the highest price. Louis, I'm not sure if that is an old hand or a new one.
And it's a new hand. I don't want to pick up on what Marcus just said about us being users of the private sector. But about 20 years ago, I needed to have my mitral valve replaced, which is a big open heart operation. And despite advice from all my medical colleagues, I went to the public sector to have it done. I had it done at Groote Hospital in the public sector. I had a what's known as a stormy course. I had 2 admissions and so on, but I'm still alive, and it's now 23 years later. More recently, and then when I went to follow-up visits, there was no one to see me. There were no doctors to see me. You know, I sat in the waiting room the whole day and no one pitched. So I went to private. And about 4 years ago, I had another life-threatening illness. And I went to the private sector, and it was, the level of care was shocking. The standards of both medical I went to one of the smart private hospitals in Cape Town, one of the highly esteemed ones. And all I can say is, I nearly died during that. But so it was all nice and comfortable and all that stuff, but the standards of care in the private sector are not good in Cape Town. And, two family experiences have shown this to me very clearly. So, again, we need a publicly owned system. But I want to pick up on what Peter said earlier about working together and sort of getting struggles working in harmony, and pick up again on what Marcus said about how difficult it is to bring everyone together for this kind of a vision that we have. How do we go about that? Finally, Mark, I just want to correct you a little bit on Henry Gluckman. The Gluckman Commission proposed for this country a single national health service, publicly owned, publicly funded, for all members of the population as a right, irrespective of income. You should read the Gluckman Commission's recommendations. If we'd done what Gluckman said, we would have been in a much better place today than we are. In fact, the Gluckman Commission's findings were very instrumental in the way that the British developed the NHS. They took it and we threw it in the bin. That's all I can say about that period. But I think you can't malign the Gluckman Commission like that. Thanks.
Sorry, Louis, it was an error, and that's what I was trying to say. But I accept the correction and the clarification, and thank you.
Thank you so much, Louis. Natalia and Mark, please make your final concluding remarks, and then we can close.
Mark, do you want to go first? I can gather my thoughts.
Thanks, Charles, and thanks everybody who's been part of this discussion. I really don't have much to say in conclusion, other than that I think it's great that there has been this interaction, and I thank you and the Climate Justice Charter movement for doing it. I think that it's great that there's been some health activists, people who are primarily have worked in the space of health in this engagement. But I would urge you to find ways to continue and to deepen this engagement so that it's not just a tick box. And I'm not suggesting that you will turn it into just a tick box, but you can see it raises many complex issues. And there is a need for our movements to support each other and to speak the same language on these on these questions. So I hope that we can get to the bottom of this and continue on it. And then the other point is, I've been a little bit blunt and frank in this discussion at times, but I think it just reflects my own rising panic that time is running out for progressive socialist, social justice movements to come up with programs and coalitions that actually build power and can bring about solutions to this crisis that we all face, because otherwise we are going to be swamped. So I'm saying, much as we need to critique everything that is external to us, we also need to introspect deeply about our ways of organizing, about our ways of building movements, about our ways of projecting movements, and so on and so on. So I don't want to go back into the substance of the discussions. I think with NHI, in some ways, it's a bit of a red herring. I mean, its only use is to allow us to have a discussion like this, because it's not going to be implemented in the short term. It's probably going to be litigated by all sorts of people, which will further delay it. And whilst we have this red herring of NHI and everybody talking about NHI, what is happening at the moment continues, which is the public healthcare system gets worse and worse and worse, and the private healthcare system continues to provide often bad quality care in a fashion that is expensive and unregulated. Thanks.
Thank you so much, Mark.
Yep, I'd just like to thank all of you, and really I've enjoyed the input, and I hear that everybody feels this sense of urgency and desperation. So the one point is around the question of Mark, the pathways and what can we do, and that's also maybe I didn't emphasize it enough. We inherited a sort of a publicly owned system that was skewed towards minority white population, and the issue that's happening now that we really need to look is to stop selling it off, because that is still happening, and I think that people are sort of talking about this incompetent and that mismanagement, but meanwhile we're selling it off. And we're privatizing, from the linen to the supplies, to the food, to the water, to the actual building infrastructure. It's just the doctors on the payroll now and the nurses. But we're selling this thing off and to profit-making entities, people who want and need to satisfy their shareholders. So I think we need to reverse that. And in fact, come up with a whole new design for a good health system. And then going back to, I think, the really important point of Peter Benjamin, I think that, again, how can we link these struggles? For me, health is so much more easier to mobilize around healthcare because it affects you, me, my children, my family. There's nobody that's not affected by health. Whether you've got medical aid or not, everyone has been affected. Everybody is worried. Whereas the climate issues are a little bit, although, we can watch it on the television, or, there is this flood and that, it's a little bit more intangible in our day-to-day lives. And I think that linking the two and making people see that, the two are inextricably linked. Health is a really good starting point to have that conversation with trade unionists, with everybody, because everybody is affected by health. So and we're all expert, people bring their great expertise and their experiences of healthcare. So I just want to thank everybody. And I wish that this initiative goes further. Thank you.
Thank you, Natalie. As a concluding remark from me, I think it's fair to say that the climate crisis that we face requires us to go beyond our small silos. It requires trade unions to go beyond worker issues. It requires environmental groups to go beyond the environmental issues. It requires coming together, a convergence of multiple forces. Because basically what we are fighting for is survival. As we say in the Climate Justice Charter, we are driven by a plurivision. That means addressing the legacies of the past, dealing with the polycrisis of today, and building a livable future, not just for human beings, but for interspecies justice. And as we work towards that, we invite everyone who was part of this discussion to join one of our policy working groups, be it on our rights of nature policy, be it on our healthcare policy, our food policy, or on our water policy. I'd like to thank Mark and Natalia for making time to be with us today. Thank you so much for such powerful inputs. Thank you for the attendees as well. We hope you'll be able to join us on the 28th of August as we have our CJCM policy workshop. Thank you to everyone. Have a wonderful evening. Goodbye.
Thanks, everybody. Go well.